All patient assessments start with ABCs. You cannot advance to the critical care level unless you start at a BLS and work your way up. So it's pretty common, and it's something that gets overlooked. But before we can advance to all these advanced treatments and critical care interventions, you still have to start with your ABCs. And we have SpongeBob to show us that. I forgot to click that one. That's okay. The first part of an assessment is the general appearance of a patient. It's their health status based on the information that you're getting from your dispatch, from your chart, from anything that you get before you get on the call, and also the first impression of the patient when you walk through the door. What do you see? This is something to gather history about your sample, your OPQRST, kind of find out what's going on about this patient, and the history of the present illness and any relating existing medical conditions. The respiratory assessment, it includes the airway. Is it maintainable or is it not maintainable? Is the airway patent or not patent? Is it going to stay that way? And what do I have to do to keep the airway patent? Do I need to give drugs, interventions, position the patient, add an adjunct, anything along those lines? Is the patient alert and able to maintain their airway, or do they require assistance? Skin appearance is listed in the respiratory because it's a great sign of perfusion, just looking at a patient. If their skin is perfusing well, it's the first thing that the blood is shunted from, so if they're not perfusing well, then there's a good early indicator. LOC is another one. If they've got an altered mental status, it's another signs and symptoms of hypoxia. It's another thing to look for. Signs and symptoms of obstruction, that's what the S-S is. It's going to include stridor, gurgling, secretions, an altered mental status, anything noted in the airway, emesis. The next part is to inspect the airway. You want to do so, see if there's any current airway interventions, any OPAs, any NPAs. This includes ET tubes, trachs, stomas, etc. Look at their respiratory status, which includes their work of breathing. Are they breathing spontaneously, or is it mechanically assisted? This was a big, bold point that children with signs and symptoms of increased work of breathing are in grave condition, and they require aggressive treatments because kids crash quick. Something else to look for, do they have equal chest rise and fall? Do they have use of accessory muscles? Signs of injury to the chest, presence of tubes, drains, lines, or anything else that gives you a heads up about their respiratory. You palpate the chest. Listen for crackling under the skin, or if you hear any air leakage, you make sure that they've got the good chest rise and fall, equal on both sides. Are there any deformities to the chest noted where there might be an indicator of underlying injury? And when you look, you want to look from the feet to look and compare side to side instead of trying to look over the patient. That was one of their recommendations. Look at the location of the trachea, see if it's deviated, see if it's in a good alignment spot. And then percussion is another technique that they talk about a lot. It's something we don't do in the field necessarily because it's hard to do, first off. Second off, you have to have a quiet, kind of calm environment to do so. The summary of the primary breathing assessment should include things like rate and depth, presence of cyanosis, presence of injury or deformity, any indicators that they're having an increased work of breathing like the accessory muscles, nasal flaring, breath sounds, and then make sure that they have good chest movement. And then obviously their O2 sat. There is a slide about percussion notes. Resonant is the sound that you hear when you do percuss over the lungs, and they recommend to take your middle finger and tap over it, and you should hear the pitch as a low pitch with a clear and hollow, and it shouldn't linger. It should just be a quick little sound. These are something that we don't necessarily listen for in the field, but they can be useful if you don't have an x-ray readily available. One of the big things that they talked about it with in the book was trying to determine if their liver is enlarged or if their spleen's ruptured or something along those lines, because you don't have an x-ray readily available, you can supposedly percuss the abdomen and determine if the spleen is enlarged based on the anatomical location of it. But this is just really interesting information. It's kind of bonus stuff. The final thing on the respiratory assessment is auscultation. Auscultation is not just one side. It's actually over multiple locations. One spot that's commonly missed is auscultating over the trachea, because stridor is an upper airway obstruction, and making sure that there's not something lodged in the trachea or that there's not airway swelling or problem there. Then you want to compare and go across the body, side to side, and not up and down, because as with everything, we compare left to right. We don't compare left upper to left lower. We want to go left, right. And they recommend all these different spots to assess for the upper lungs, the middle, and then the lower, to try to make sure that you have good lung sounds and good clear breath sounds throughout, so you have good air movement all out. They have anterior and posterior locations. They also want you to note breath sounds being normal upon location. You want to hear some quieter lung sounds in the base, but you don't want to hear them up top, and you don't want to hear like the tracheal sounds. You don't want to hear past the midline. When you listen to them, and I've got videos attached in the next section, you'll hear how they're kind of louder and their pitch is slightly different than what you'd hear lower in the lungs. So it'd be an abnormal finding to find those lower. Next is cardiovascular. We do the same things. We inspect. Is there cyanosis present or clubbing, showing that there's signs and symptoms of long-term hypoxia? Is there edema? Is it pitting edema? We grade it on a scale based on how we touch it, and does it sink in or how quickly it rebounds back. Look at their ECG. What's the underlying rhythm? Any arrhythmias noted? Are there any treatments performed, whether they are pharm or electrical, and what was the patient's response to the treatments? Assess a pulse, parotid, radial, brachial, femoral, popliteal, posterior tibial, and dorsal pedis. Assess for rate, strength, and pattern, and yet again we compare on each side, especially in instances where there's an injury to one side. You want to make sure that the limb is still perfusing well. You auscultate heart sounds is another thing that they look for in cardiovascular. Aortic, pulmonary, tricuspid, and mitral. You look for pattern, intensity, quality, and pitch is something that you look for with those. And when you're auscultating heart sound, the important thing that we do need to check in the field, and we need to do more often, is to make sure when we have a patient with an abnormal heart rhythm that we listen and we make sure that all the beats are perfused. So we feel their pulse as we're listening, especially with PVCs and PACs. Just because it shows up as electrical activity on the ECG monitor, it doesn't mean that that beat's perfused. An example would be a patient with a rate of 80, but they have bigeminy. So really, they have a perfusing rate of 40, but they have an electrical rate of 80. So if we were to take away the 40 beats that were not perfused, they really just have the 40 beats, which makes them bradycardic, and they'd probably be symptomatic. The summary for that is to check pulse rate and quality, skin color, appearance, peripheral pulses, temperature, I's and O's meaning input and output, and their blood pressure is another good thing to note. They want you to note trends though. An individual blood pressure doesn't necessarily help, but noting if it's gone up, if it's gone down, and kind of a long-term trend to see how the patient's doing. Neurologic. You assess a GCS scale. That is a very good scale to use because it's very objective. It doesn't have a lot of opinion based into it. And it's got a good, everybody knows what it means, and it's got a good, widely known base. Assess the mental status. Are they alert? Alert to verbal stimuli, alert to painful stimuli, or unresponsive. Check their pupils. Note that their pupils can be assessed for shape, reactiveness, and size. And then also for their eyes, are they open? Are they equal? Check their posturing. Is it decortibrate or decerebrate? And then I included a little picture. Gastrointestinal. You inspect the mucous membranes in the oral. They should be wet. They shouldn't be dry. Without lesions. If they're dry, they could mean dehydration. Make sure there's no blood. You'll want to note if there's any swelling or bruising. You auscultate over the abdomen if you're going to do so before you palpate and percuss so that you don't get a false positive for bowel sounds. You can do percussion, like I talked about earlier with the liver, and I put notes into the PowerPoint so you can see the exact technique and the procedure. And then palpation, is it soft or hard? Is it tender or non-tender? If it is tender, do they have rebound tenderness? Is it distended or not distended? And one of the special little signs that we look for is Murphy's sign. It's severe right upper quadrant pain, and it worsens upon palpation or inspiration, and it's an indicator of cholecystitis. And that's listed on a lot of test questions. It'll have which sign indicates this, or this patient has a positive Murphy's sign. What does that indicate? So some of these signs are kind of important. Genitourinary and musculoskeletal. You assess for kidney function, the serum creatinine level. The more destroyed the nephrons are, the higher creatinine, because they're not able to excrete the creatinine throughout the urine. The kidneys can become prone to metabolic acidosis if they're not able to clear the byproducts, and they can also be prone to anemia as well because a diseased kidney doesn't have the ability to make the hormone that causes the red blood cells to be made. Let's see. If not on dialysis, if they are a renal failure patient, you want to make sure that you palpate the AV fistula. You want to check for the thrill, which is palpable, and the bruit, which is audible, to make sure it's working. And you want to make sure that if it's not, you note so appropriately because it could mean a clotting within the site. Those should only be used during dialysis. They should only be used during dialysis. We should not access hemodialysis ports unless it's life or death. Gotta have it. And if you have to do so, it must be done with a sterile technique. The thing about musculoskeletal is it can kind of provide you with a secondary diagnosis, and you should splint extremities in the position of rest or with good radial pulses. And all of that needs to be done before transport, obviously. The last thing to note about this presentation is the scene versus interfacility transports. I passed out a packet, and it'll be online about some different information you can gather, especially if you're on a interfacility transport. We have access to a lot more information than we do on a scene. But on a scene, you want to evaluate based on what you see, and on an interfacility, you want to take what you can find from the paperwork and try to piece it together to get all complete pictures. On the scene, you get to see everything right in front of you, and in our facility, you want to try to piece that together and find out everything that's happened before. You want to look at the current interventions, the responses, and the patient status. And like it says in here, just refer to the handout, which will be on the shared drive as well. Something else to note on the scenes, we can notice the mechanism of injury, get some details if they were like an MVC or in some kind of trauma, and kind of notice and predict what kind of injuries they're going to have based on that. And that's it for that presentation. It took like 20 minutes. You guys are so thrilled to be here. Right? You want to play a guessing game?
Sad.
What?
It's a game where you guess things.
No, we're going to play the heart and lung sound guessing game. It's pretty cool, if I do say so myself.
Might as well. You got this, Art. Me and I'll be over here.
Andy, you can help play too.
Can I kill stuff?
No, you can't kill stuff.
Well, no, I won't play.
That's the point of this, is to save stuff, not kill stuff.
Maybe I want to kill stuff.
I have 2 videos that curse. If you have small children around, mute the video. It was cool. This is what the love dove should sound like. The animation that you'll see shows you what is actually going on within the heart and with the valves when it's happening. I thought this was a good video because it shows you what you're listening for. And it's like 10 seconds. So. Patient has 3, which is abnormal. hard to hear. You might have to listen to this at home with headphones. It's really quiet, but it almost sounds like a blowing noise in my opinion. In the last two videos, oops, are actually some of my favorite.
This is a heart. Atrium, ventricle. V on the bottom for ventricle. The heart has 4 valves, remembered by mitral pulls all. Like a tube of toothpaste, the ventricles squeeze from the bottom. So, mitral and tricuspid valves close first, then pulmonary and aortic. You can hear these valves slap closed through a stethoscope. Love dub, or fuck you, Kentucky, Kentucky, or fuck, you're screwed. When your heart fails, you're screwed. S4, Tennessee, or fuck you. S4 is caused by stiff ventricle. The atrium has a hard time pushing blood and says, fuck you, Mr. Ventricle. Help hippo. Help support the Hippocratic Oath.
I like that one. There's another one on there as well. It's funny and it cusses. And it just explains the pronunciation and how to get it working. Who wants to go first guessing? Nobody? Alright, Andy. Ready?
What am I guessing?
I'm going to play a lung sound for you and you just guess what it is. And this is the discussion point of the night.
I know the names of the sounds.
What?
I gotta know the names of the sounds.
You don't have to know the name of the sound. You have to guess what the sound is. That's the point.
I don't understand. I'm trying to think. That's a blue whale. It's a blue whale.
It's not a blue.
It is a blue whale.
Art, do you know what it is? I can play it again.
Yeah, play it one more time. It almost sounds like wheezing, but it
is.
Is it?
Mm-hmm. These are just some examples of what it sounds like, and they're really over-exaggerated, but it helps to give you a good idea what they sound like. Alright, do you want round 2?
Sure. Keep this one.
No, seriously. What do you think that one is? I'll give you a hint. It's Ronca or Crackles.
One more time. Okay.
It is Ronca.
Hey, which one of those sounds are used interchangeably? Like they mean the same thing. Is that
Rails
and Ronca? Or rails and crackles? Or
I think it's rails and Ronca are interchangeable, aren't they? You can Google it. Rails and crackles, you're right. Rails and crackles, I was wrong. I always get them rails and Ronca, that's what I'm thinking.
see, I do too.
Here's the last one, Art. You only have one choice of what it could be, so.
Is that Strider?
No, it's crackles.
Crackles?
And crackles occur when the fluid moves over, or the air moves over top of the fluid, and that's what creates the kind of bubbling sound. So it's kind of cool. And then there's another video attached on here that you guys can look at. And it plays, it shows you the sound waves as it's displaying them, and it names it and gives you the pathophysics behind them, so it's kind of cool. Fun stuff. And then the last thing we'll do is the scenarios. I don't trip over the cord. This is kind of a brief brief what we went over today? All right. Who wants to go first? Art, you want to go first?
I'll go first.
1, 2, or 3? Which are numbered, by the way, for people at home.
2.
2? All right. You've got an ALS truck, and you have a BLS partner. It's 7 o'clock at night. You're going to an apartment building. It's about 56 degrees outside. You're responding to a person down, possible seizure. You arrive on scene. There's broken glass on the coffee table near the patient. He's laying on his left lateral side in between the couch and the coffee table. He's awake and tracking EMS crew members as they approach. However, he appears confused. Skin is flushed, hot, and moist. Airways open. Breathing rate and effort appears normal. He's a 19-year-old male, approximately 170 pounds. And that is your scenario. The patient's roommate's there. He's on scene and he's anxious. He says he was sitting next to the guy watching TV. He had a sudden change in consciousness, fell forward, hit his head on the glass table, and then he started this full shaking thing where he was like flopping around. And he called 911.
Okay.
So what is your assessment of this patient as we walk through it? That's kind of what the point of tonight is
Do
to
I
get through.
see any drug paraphernalia, alcohol?
You do not. There's
Okay.
none.
Well, we're going to take C-spine precaution since he fell and hit his head.
Okay.
Treat him like a trauma. From the description, it kind of sounds like seizures. Does he have any history of epilepsy or?
He does for the past 10 years.
Okay.
But what we kind of want to focus on is, what's your general impression of this patient?
Well, he's sick.
Mm-hmm.
Seizure activity. What's his mental status? He can track with his eyes.
He's oriented to person and place only.
So he's still in that
Postictal, yeah.
postictal state.
So what's his respiratory assessment that you'd provide for this patient? What do you think based on the information given?
Well, I check lung sounds.
Okay.
What are those?
They're clear.
I check his heart while I was there. I mean, just listening.
They're within normal limits, and his pulse rate is 118. It's just a sinus rhythm.
Okay. And his skin is hot. You said flush.
Mm-hmm. Hot and flushed. So we kind of covered his respiratory, his cardiovascular. His neuro we touched on with an altered mental status and the seizure.
Yeah.
His gastrointestinal would be within normal limits. His genitourinary is within normal limits. And musculoskeletal, he's got a lack to his head.
Did he urinate or anything?
Mm-mm. So, after the assessment of this patient, would you still say sick is your general impression?
I would say not sick, but he's certainly not normal either.
Mm-hmm. Okay.
He can have another seizure, so we'd want to be on the lookout for that.
Mm-hmm. So, when you're assessing a seizure patient, are there any things that kind of stick out that you want to look for?
You want to make sure there's nothing around they can hurt themselves on.
Yeah, and we had the broken glass. Are there certain specific questions we want to ask about his neurologic assessment since we know he had a seizure? Like, how long did it last? The roommate said he's flopping around, so...
How long it lasts. You could get the roommate could describe it for us, so you could kind of narrow down what type of seizure it was.
I like that you mentioned drugs. That was a good thought. He has a history of epilepsy in this case, but that's a good thought.
So with seizures and epilepsy, you don't want to expose them to stimuli like bright lights or flashing lights. Do you remember Titanic?
Yeah.
You remember all the epileptics that had seizures during that because when they was showing the ship and the electrical stuff was short-circuiting, so it was flash, all the flashing. A lot of the people had seizures.
Nice. I think that was before my time. What?
It's nice.
I thought everybody.
That is nice.
I thought everybody else seen Titanic.
I've seen it, but I watched it on like the DVD thing when it was redone.
Somebody said they took that scene out or made it so it wasn't
That bad?
visually disturbing.
Yeah. I could see why. That'd be an interesting day at the movie theater. Have a bunch of people start seizing. Especially if you've got a whole family of them. That would be god-awful. So that's kind of the scenario that we touched on for the seizure. We covered all aspects of an assessment, and an assessment needs to be a complete head-to-toe, thinking on every single body system, and try to be as detailed as possible. Even the smallest little things can help give us a good sign of what's going on with our patient. What's written on the board is just all the systems and parts of the assessment. The 4 different things we need to do: inspect, palpate, percuss, and auscultate. And then the traditional airway, breathing, circulation, disability, which is neuro, and exposure. All right, Andy, 1 or 3?
6.
I'm surprised he didn't say 4.
I know. You're getting 3, because 3...
I want 1.
You want 1?
I don't care.
Okay. All right. You have a 350-pound patient who is pale, cyanotic, and diaphoretic, man down with a possible syncopal episode at 1 o'clock in the afternoon. It's 80 degrees outside. Like, that matters. You're going to an upstairs bedroom with a narrow staircase and a hallway. I know. I'm terrible today. He's pale, diaphoretic, cyanotic, anxious, positive Levine sign, sitting on the edge of the bed. 64-year-old male that's 350 pounds. His wife is anxious and on scene. Their unkept bedroom with vomit on the floor. Negative mechanism of injury, nature of illness, and a sick male. So, go through your assessment on this patient. Well, hey, he's obese, yeah. That's a good point.
What's the neighborhood? Is it a good neighborhood? It's a bad neighborhood? Just a neighborhood.
You're in the ghetto.
I'm in the ghetto. I'm in my home. So walk in my house. You said there was vomit on the floor in the bedroom. This is where the patient is.
Yeah, he's a warder. There's vomit and stuff everywhere.
He keeps vomit. That's
Well, no.
a whole different issue right there. There's vomit on the floor anyway, so
Yeah.
the oven doesn't clean themselves up. Anyway, so things don't get clean. It's just a dirty house. Is he wearing clothes?
He's wearing boxers.
Doesn't. So is he alert? Is he ordered? I walk in the room. Is he looking at me? Have you said all this before?
He looks anxious and diaphoretic. He's got a GCS of 14 because he's unable to answer questions.
Now, is he unable to answer questions because he just can't answer questions, or he just doesn't want to
Because
answer questions?
he's breathing really fast and he's having trouble speaking.
Okay.
And he's got a weak radial pulse at 104.
Spit us up.
What?
Nothing. Anyway. So, all that stuff's going on. So, I mean, he does answer questions appropriately as far as how do you know where you are right now?
Mm-hmm.
As best he can respond.
Correct.
I'm at home. I feel like crap.
Correct.
All right. What was he doing before all this stuff happened?
Scroll down. No wonder these things are so hard to read. He was sitting at home watching TV, had a little bit of chest pain, got excited over Wheel of Fortune, just hurled everywhere. It is. He hurled everywhere. It was Pat, and Pat got him all worked up. He did.
Okay. Has he been sick recently?
He has not.
Not been sick recently. All right. So he's talking to me as best he can. So his airway is open at this time. He is breathing, although his breathing, you said, fast and shallow.
Mm-hmm.
So he's breathing fast and shallow. A lot of fat people breathe fast and shallow. To be honest with you, I breathe fast and shallow. So he's breathing on his own. His airway's open because he's talking. His mental status is normal, best you can tell, because he's answering questions appropriately, just not able to answer as much as you need to. You said he's sweating?
Yeah.
So he's sweating.
Diaphoretic, pale.
And he's got weak pulses, so his perfusion's not as good as it could be, but I don't know how it is usually. Since he's in his boxers and he's laid up on his bed,
Mm-hmm.
I'm going to check his pill pulses. Are they even weaker, or does he have any?
He has none, and they look just ginormous, and you touch them and your fingers kind of sink in there.
So he's pitting edema, so he definitely doesn't have them. His circulation is definitely not the way it should be. What is his prior history? Does he have a history of CHF?
Well, his wife hands you this bottle of something. She says she thinks it's called Later.
Viagra.
No, it's not Viagra. She thinks it's called Later. She hands it to you, and it's it's Lasix. I can't pronounce it. Firmoside.
Mm-hmm.
It's Lasix, and then he takes an aspirin every day, just because he's old and fat.
Okay, so is he taking some medication the way he should be?
I mean, yeah.
Yeah, sure.
Yeah, he's been taking it like he's supposed to. I mean, he's put on a little bit of weight here over the holidays, but nothing too bad. I mean, well, maybe it's been a lot. I mean, he did eat the turkey.
He did eat the turkey. So he
No, I mean, like, he ate the turkey.
Well, good for him.
Like the whole bird.
Good.
So he's put on a whole bunch of weight.
So, a lot of weight increase recently, fairly recently. So,
at least that's what we think it is.
Going through the just the ABCs of everything, the BLS thing first. Again, he's breathing on his own. He's talking, so his airway's open. His pulse is a little on the crappy side. The skin's a little on the crappy side, both of which could be due to poor circulation. He has pitting edema, so it's definitely a poor circulation. He has a history of some kind of possible CHF or some kind of fluid overload because he's on Lasix. Probably it's an exacerbation of CHF and stuff. How was pooping? Has he been pooping?
Yeah.
He has been pooping?
Yeah.
Like a lot? Or just like
normal.
Like normal pooping?
Yeah.
Okay. So I mean that's what I would start off with. So I mean you're gonna check your vital signs, check his blood pressure.
So if you had one aspect of the assessment that you'd want of one of these assessment parts, the appearance, respiratory, cardio, neuro, GI, musculoskeletal, which one would you kind of want to go down that route and expand on? You kind of said it. Which one of those do you want to ask a whole bunch?
Cardiovascular.
Yeah.
I mean, because he threw up, but that he could have a GI bug, but that doesn't help any that he feels like crap, and so it could be the fact that
he's anxious, short of breath, weight gain in the past couple of days. Lasix is a weight-based medication. No, it's not. He just gained a ton of weight recently. He's got fluid buildup. So, yay.
Talking about the turkey.
Yeah, he ate the turkey.
Oh, damn. I'm sorry, can I say that?
Yeah.
Okay, good.
Why not? So that's the assessment. The thing they want you to think on is just to think outside the box too. So, and to look at all the stuff that's in your little packet and look down the thing and see that there's like 10 different questions for each aspect of each assessment, and it's things you'd never think of when you're on the moment, but it's some things that we should be considering more often. In the moment, I know. Like we did a lot of cardiovascular and GI and things like that, but it's also kind of a respiratory thing, and it could be one of 2 or 3 things that are all mashed together, and it's trying to figure out what exactly is going on. There doesn't have to be one answer, and there could be a lot going on. And that's it. I kind of adjusted this one a little bit, because this one was jacked up. It really was. Like, it's talking about a lump that you find upon examination of the chest, and the patient don't know where it came from. And then they have bigeminal PVCs, and they got pitting edema, and they're vomiting. Like, this guy's crapping out. And I was like, that's too hard. That's too hard for what we're doing today. We'll get there. Don't worry, this is going to get harder. But hey, I mean, we get like an hour worth of CE. So yeah. That's all I have for patient assessment. It's a cut and dry topic, but a lot of the stuff in the book was, it was like equipment-based stuff.
Yeah.
Like there's a whole 10 pages. A whole 10 pages of teeny tiny font. Or it was god awful. About different types. Check your equipment, check your transport team, check your patient, check your monitor, check your IV pole, check your meds, check this, check this. It was like all kinds of check. I'm gonna cut it out, so it's okay.
Fuck.
I'll edit it out.
Let's put beeps over it.
If I knew how I would, I'd put like a sheep noise or something.
Do that, bleep out. You up there just making you beep out everything. Like random.
It's a lot. I'm looking forward to next week getting into the flight physiology. 'Cause that was really hard. I scored like a 50 on that practice test. Because it's all about gas laws and calculating altitudes and calculating FiO2s from one place to another. I don't know how to do that. You know how to do that?
Mm-hmm.
It's a formula and it's like this long on a teeny tiny
I
font.
know how to do that.
Alright, Andy, what's formula?
It's,
See, the thing of it is, there's machines that figure that out for us now. So,
I know, it's super hard though.
when's the last time you've seen somebody in the back of an ambulance doing one of these big formulas?
Mm-hmm.
formula is
The big thing about the flight physiology is going to be remembering like Boyle's law. When they go way up in the sky, the ET cuff might deflate because the pressure's not as high, but the Foley balloon's going to be just fine because it's full of water, not air. And it's stuff like that you know what I'm saying?
Well, you know, if you noticed it, if you get a blood pressure going over Afton Mountain, it's a lot different than, you know, your reading can be way off. I noticed that a couple of times when we used to go to UVA all the time.
It's got the pathophys for it. It's true. Just saying. It's not a very exciting topic tonight, I'm sorry. It's cut and dry, but it was one to cover, so. Next week should be pretty cool, though. Dr. Bernier said she'd come and teach.
I like her. She's charismatic when she teaches.
I know. I'm just going to say let loose, cuss as much as you want, because it's going to end up on YouTube, and if I have to label it something different so it's okay, I'll make it okay. Because
I get that option.
Because you would never stop cussing. No. I really like that packet, though. I saw that and I was like, I love that in the book. Because it's got all these different things. Because you'd never think about some of that stuff. Like, who the hell checks genitals on all their patients? Andy, you would.
That's perspective.